You see my slide?
Yes po, Doc.
Kita na ninyo? Sorry ha, kasi dapat we should have our lecture this morning, but I had my booster shot. So kamo ba ngayon, nagka-aanuhan na kamo? Nagkababakunahan na? I encourage you to have your booster shot, ha? Kung mag-ano itong school, pagpaano gihapon ka mo, pagpa-booster shot, ha?
Yes, Doc.
Okay, we'll start with our we'll start with the examination of the heart, the precordium. So to start with, we inspect the heart or the chest, I mean, for any movement, precordial movements. And then inspect also if there is visible pulsation on the chest, and if the point of maximum impulse is visible. Now, if it's visible, you locate where the area of the point of maximal impulse is. For example, kung you have seen the PMI as diffuse, you also have to measure the diameter of the PMI or the apex bit. So this is your precordium. So this is the area of your precordium. It is bounded from the second ICS up to the nipple line or mid-clavicular. So along the second ICS, on the right side, your left sternal border, and then right sternal border, sorry. Right sternal border, on the left side, the mid-clavicular line. And then inferior from the fifth ICS. So below the fifth rib or the fifth ICS. Okay? That's the boundary of your precordium. So when you inspect, you look at these different areas for any pulsations or mga bulging, whatever. So this one is your sternoclavicular area. This is your aortic area, your pulmonic area, and this one is your right ventricular area. Subot nga. And then you have your epigastric area, your apical area, this one, and your Erb's point for your ectopic area. So these are the areas where you will inspect and you will palpate for any mga pulsations or the presence of your thrills or hips. So same pa rin yan, ha? You just put the heart here and you will see what are the structures that you will be able to appreciate. So at the second ICS, this is the area of your aortic. So the aortic valve, kasi di ba aorta ito? So this will be the area of your aortic valve. And one is the pulmonic area. So it's actually, or you can even hear also that or palpate pulsations opposite han imo second ICS on the right, so adin na left side. And then you have your this one, this is the area of your right ventricle, and this is your apex. So you take note of any deviations of your apex. So if the apex bit is deviated, this means that there is probable hypertrophy or enlargement of the left ventricle, because this is your left ventricle. And then take note also, kasi minsan there are pulsations in this area, the epigastric area. So epigastric area, di ba, this will run through din your aorta. Yung Erb's point is the lateral side. The lateral side of the heart, or even this is still the RV or RV kasi naka-twist kasi yan, ha? Okay. Same pa rin siya. So, this is your heart. This is the cardiac shadow. So this is your aortic knob. So this one is the area of your right ventricle. You have to be imaginative para ano. This is the area of your right ventricle. This is the area of your left ventricle. So this is the apex. So in radiology, you will be taught how to read basic x-rays. Okay, that's the pulmonic area. That's the right atrium, the left ventricle, tapos your left atrium, and your aorta. Then your superior vena cava. Okay. The chest is by convention divided into segments by reference lines. So you have the mid-sternal line, which bisects the sternum from up then down. The midclavicular line is also called as your nipple line, which is midway between the midclavicular line and the acromioclavicular joint. The anterior axillary line, this is perpendicular to the anterior fold of the axilla. And then the posterior axillary line is perpendicular to the posterior fold of the axilla. And the mid-axillary line is between the two preceding lines. So between the posterior and the anterior is your mid-axillary line. Okay. So ito yon. Your A is this is mid-sternal. So dito ano yon, yung area, this is where your aorta. You can hear kung may mga bruit here. So you listen. Then B is your mid-clavicular line. So this is your mid-clavicular line. So halfway hemoclavicle is your mid-clavicular line. And then this one is your anterior axillary line. So ito yon. If you on the lateral view to. So E is your anterior axillary line, your F is your posterior axillary line, and midway is your mid axillary line, huh? So you describe the chest, whether it is barrel chest. So it is usually barrel chest in patients who have chronic obstructive lung disease. The abnormality here is because of the what's this, your chest is barrel. There is usually scoliosis of your spine, and then pagkaifos, sabi nila nakaliad. This is because of this is, what's this? Compensatory. Later kasi nadapo. So it may cause, because of the anatomy or the configuration of the chest, this may cause hypoventilation or respiratory acidosis. and later cor pulmonale. So you can also observe bulging of the left precordium. So if you have bulging of the left precordium with visible systolic heave, this is commonly seen in patients who have severe mitral stenosis that has started during childhood. If you see a seesaw motion of the chest wall, and there is also a systolic outward thrust of the right chest and pulsation of the neck veins, this is seen in in patients with severe tricuspid regurgitation. Now, if there is an upward thrust of the upper chest and shoulder with nodding of head, this is commonly seen in patients with severe aortic regurgitation. So you have to be to look closely at your patient when you are doing your inspection, because these are some clues that will tell you what the problem, what cardiac problem the patient has. Now, bulging of the upper sternum and sinking in of the lower portion of the sternum. So na excavate ba? Binisaya, winaray. Nalupok. Oo, nalupok. So there is sinking in of the lower portion together with the attached ribs. This is seen in interventricular septal defect, or it suggests presence of interventricular septal defect. Now, if you have bulging of the area of the left, second, and third interspace with visible pulsations, this suggests interatrial septal defect. Now, in adults, the bulge of the left, fourth, and fifth intercostal space also suggests interventricular septal defect. Now, a bulge with pulsation farther out in the left precordium, meaning at the third, fourth, and fifth intercostal space, this may suggest presence of ventricular aneurysm. If there is a bulge, upper sternal bulge in an adult, this suggests glutic aneurysm of the ascending aorta. Kasi di ba, the sternal angle, or is the at the upper portion of your sternum, you will below that is your aorta. So if there are a bulging on that area, this may suggest glutic aneurysm of the ascending aorta. Now, we also examine abdomen. Part of the examination of the heart is to look at the abdomen, kasi there are also some clues that will tell you that this patient might be suffering from a right-sided failure. Like, for example, you have ascites. So this is seen in patients who have chronic right-sided failure. So as part of generalized fluid retention. So in right-sided failure, this may be the result of pulmonary hypertension, so secondary to a mitral valve disease, like mitral stenosis, or as I mentioned earlier, from cor pulmonale. So a constrictive pericarditis also may present with ascites, and this appears to be out of proportion to fluid retention. So in such cases, you will have an enlarged liver. So this spleen may also be enlarged in some patients. So if you have an enlarged liver pulsating during systole, so this indicates tricuspid regurgitation. So ascites also may be aggravated by the development of cardiac cirrhosis. Now, in thin individuals, abdominal aortic pulsation may be visible in the epigastrium. So if you have presence of expansile pulsation, this suggests abdominal aortic aneurysm. So you have pulsation in the abdomen. So it may suggest abdominal aortic aneurysm. Now, if you have hypertrophy of your right ventricle, this may cause a pulsation or visible and palpable downward pulsation at the epigastric area. Kasi diba, your right ventricle is located mid-sternum and it is near the epigastric area. So that's why you can have visible and palpable downward pulsation in that area. Now, you also have to look at the lower extremities because there are also some clues that will tell you that the patient may be suffering from a cardiac problem like the edema. So if you have cardiac edema, this is usually dependent, and in ambulant patient, you can see this edema on the feet, the ankles, and legs, or in the early stages noted at the end, also noted at the end of the day. Kasi di ba nagtitinok daw, so they are usually dependent edema. So it's in the ankles, the feet, and the legs. Edema also may be noted at the presacral area if the patient is in the recumbent position, mga bed patients, bed-bound patients. So your peripheral edema may also be due to presence of your varicosities. Now, if you also have thrombosis of the inferior vena cava and its tributaries, or there is lymphatic obstruction as in Bancroftian elephantiasis, but usually in elephantiasis, it is unilateral. So if you have a arteriovenous fistula, this may occur in the leg vessels so that one leg may appear better developed. They are longer and warmer than the opposite leg. So generally, you will appreciate cyanosis and clubbing in some patients with cardiac problem. So if the cyanosis and clubbing is cardiac, you will have the affectations of your cyanosis in both hands and feet. In patients also have ductus arteriosus with reversal of the shunt, the toes may be cyanotic and clubbed, and the fingers are pink and normal, except those with of the left, which may be slightly cyanotic and slightly clubbed. So after your inspection, you will proceed with your palpation. So when you palpate, you use these different parts of your hand. So the distal tip of the finger pads, this is used for localization of pulsations. Huh? Now, if you, for this portion, the distal portion of the palm, this one, this is used for localization of presence of thrills. And this part, we call this as the proximal part of the palm or the heel of the palm. This is used to localize presence of hibs or a lift. So the different parts of your hand has different uses for localizations of the different pulsations, thrills, and hibs. So hibs and lifts. So you need to take note if there is a hib in this area, the aortic, the pulmonic, and the LA, and the RV, and as well as the LV. So the apex bit, so during diastole, your apex bit is located at the partially rotated here, gamay. So this is where your left ventricle is, and it is mostly the right ventricle on the anterior portion of your chest, di ba? During diastole. But however, during systole, so there is a counterclockwise rotation of the heart, so that the apex will strike now the wall. Kaya you can appreciate the apex beat, especially kung hypertrophied ito ang imo left ventricle. Pero during diastole, it's very difficult. Or sometimes, kung talaga makapal na yung muscle, hypertrophied, you can appreciate what's this, a heave. So for your apex beat, you need to determine where the location of your apex beat. So it's part of your recording in your cardiac examination to record where the location of the apex beat, where you have noted the apex beat, and then the diameter of the apex beat, as I have mentioned kanina. You need to measure the diameter of the apex beat, the amplitude, meaning to say, makusog bahya or faint, and then the duration. So, what about its, is it affected by breathing? So you let your patient breathe out and briefly stop breathing. Kung hindi siya nawawalaan dyan, so you can actually easily locate where the apex beat is. So that's one maneuver. Kasi minsan, nahirapan kayo to locate the apex beat because there are other pulsations. So you can do this maneuver. So the apex beat is most lateral. It is a palpable ventricular impulse. So patient should be sitting, pwede yan, sitting. So if the patient is sitting, it is approximately 10 cm from the mid-sternal line. So mid left thorax at the level of 4th to 5th ICS. So this is felt on one intercostal space that is less than 2.5 cm. So it's not more than 1.5 fingertips wide. It is small and feels like a gentle tap. So that is the characteristic of your apex beat, huh? So with palpation, so what's the character of your apex beat? So normally it will rise, it rises and retracts quickly by the first half of systole. So it may last up to the first 2/3 of systole. However, if you have left ventricular hypertrophy, you will have a sustained apex beat and falls after your S2. Now, if you have displacement of the apical impulse downward and laterally, this indicates left ventricular enlargement. So displacement of the apex beat or the apical impulse downward and laterally indicates left ventricular enlargement. Now, in lesions of the left side that will cause systolic overload, the hypertrophied ventricle may not be enlarged, but they will have concentric hypertrophy. Hindi siya malaki, but you have hypertrophy, concentric, makapal yung muscle. So that the apical impulse is not displaced, but rather you will appreciate a heave. So there is heaving. But rather, is a slow, sustained, strong and broad upward lift that does not disappear even with fingertip pressure. So that's the characteristic of a heave. It will not disappear with fingertip pressure. Kasi kung minsan, mamisled kayo from a pulsation and a heave. So a heave is a slow, sustained, strong, and broad upward lift that does not disappear with firm fingertip pressure. So if you have cardiac dilatation, in addition to your apical displacement, this will have a wider and a more diffuse impulse. So may displacement na siya, at the same time, the impulse is diffuse because you already have dilatation. Now, the apical impulse also may be brisk in hyperdynamic states like when there is fever, or you are excited, or in the presence of hyperthyroidism. So in mitral stenosis, you will appreciate a tap, a definite tap, which coincides with the snapping of the first heart sound. So there is a tap that coincides with the snapping of the first heart sound. So this is common in mitral stenosis. Now, so during systole, the lower precordium retracts, so it will retract. But if you have extensive retraction of the lower precordium with the presence of a diastolic impulse, this is seen in patients with constrictive pericarditis. Now, if you see a sustained heave or felt a sustained heave below the third rib parasternally, this indicates a right ventricular hypertrophy of the systolic overload type. So this is best felt by putting the heel of the right palm on the area. So this is seen in mitral stenosis with pulmonary hypertension. Now, in thin-chested individuals, you will appreciate a left parasternal impulse. However, this is not a heave. Ito yung sinasabi ko minsan, you will be mistaken for the lift is mistaken for, especially in thin-chested individual, as a heave. Left parasternal impulse. So heart sounds may be palpable normally in young and thin-chested individuals. So in older individuals, however, a palpable second pulmonic sound may be an early sign of mitral stenosis and indicates the development of pulmonary hypertension. Now, thrills are palpable equivalents of a loud murmur. Now, if it is systolic in timing, the thrill is systolic in timing, meaning to say the thrill occur with the apical impulse, it is systolic in timing. Now, it is diastolic in timing, your thrill, if the occurrence is before the apical impulse, or continuous if they occur throughout systole and diastole. So this is how you describe a thrill. So whether it is systolic in timing, diastolic in timing, or it is continuous. So systolic if it occurs with the apical impulse. Diastolic if it occurs before the apical impulse. And continuous if it occurs throughout systole and diastole. Okay? So the whole hand and fingers may be used when you are or you want to detect presence of thrill. All of your hands and fingers. The hypothenar surface is the most sensitive part of your hand, and the non-dominant hand may be better since the palms may be thinner. Kasi kung, di ba kung, for example, you use the dominant hand, you are right-handed, for example, you use your right hand, makapal na, you have callus, and you may not appreciate the thrill. So you use the non-dominant hand so that you can easily appreciate the presence of a thrill if there is. Kasi wala siyang callus or it is thinner. So the apical area, you need to look also if there is or felt of, you have to palpate for systolic thrill, suggesting that you have mitral regurgitation. If there is diastolic thrill in this area, this may suggest presence of a severe stenosis. Now, in the lower sternal and mid-precordial areas, the presence of a systolic thrill also may suggest tricuspid insufficiency or interventricular septal defect. At the Erb's point or the secondary aortic area, if you palpated a systolic thrill, this may suggest aortic stenosis or high-lying interventricular septal defect. If you were able to palpate a systolic thrill at the upper right parasternal area and the carotid vessel, this is most probably secondary to an aortic stenosis. Diastolic thrill at the Erb's area also may suggest severe aortic regurgitation or pulmonic regurgitation, while a diastolic thrill palpable at the aortic area suggests aortic regurgitation, while a systolic thrill at the pulmonic area suggests pulmonic valvular or subvalvular stenosis. Now, in infants and young children, a continuous thrill may be appreciated at the upper left parasternal area, suggesting the presence of an aorto-pulmonary communication, probably from a patent ductus arteriosus. So next is percussion. So we do not routinely perform percussion when we are doing cardiac examination. So usually it's inspection, palpation, then auscultation. But there are instances where you need also to percuss. So the patient should be in a recumbent position with the chest exposed, as in when you are doing inspection and palpation. And the examiner stands on the patient's right. So percussion is performed by tapping the index or middle finger of the left hand. You know this already when you do your percussion of the chest, diba? The pleximeter, you hyperextend in the intercostal space, and then by the bent middle finger, so nakaano yung middle finger, the flexor perform perpendicular to the pleximeter with a brisk stroke. So you tap the pleximeter with your flexor. Huh? So this is how this is done. So tapping is done from the outside, going along the second, third, and fourth, left and right interspaces, and then above the area of the liver dullness on the right side, towards the apex on the left side, and the retrosternal area. So percussion may be limited when your patient is obese or there is a huge and pendulous breast. Also in cases of pulmonary conditions like when there is emphysema, pneumothorax, or you have pleural effusion and marked elevation of the diaphragm secondary to pregnancy or from ascites. Normally, at the level of the second left intercostal space, there is no dullness up to the left sternal border. So the cardiac border here is formed by the main pulmonary artery. So the sternum itself at this level is just slightly less resonant. Now, at the level of the third left intercostal space, there may be an area of relative dullness, about 2 cm to the left of the sternum. So the cardiac border here is formed by the right ventricular outflow tract, and behind this, projecting somewhat anteriorly, is your left atrial appendage. So at the region of the apex, you will have relative dullness, and this corresponds to the PMI normally, and as you proceed medially, the area of absolute dullness is reached. So this is the bare area of the heart and extends up to the fourth interspace and to the sternal border. So on the right side, right side at the level of the third and fourth interspace, no dullness is encountered to the right of the sternum. So the cardiac border here is formed by the right atrium. So there is no dullness normally on percussing the sternum below the level of the fourth rib. In the upper sternum, relative dullness should not extend beyond the sternal borders. So if you have left ventricular hypertrophy and dilatation, the area of dullness extends downward and laterally with the apex. When there is marked increase in area of relative dullness with a non-palpable apex, and especially of relative dullness outward at the level of the third and fourth intercostal space, as well as retrosternally, this suggests that your patient has pericardial effusion. Now, presence of retrosternal dullness at the level of the fourth rib downward suggests ventricular enlargement. If you have presence of increased dullness at the level of the third left sternal intercostal space, this may suggest enlargement of the right ventricular outflow tract or of the left atrial appendage. Now, presence also of dullness beyond the sternum at the level of the second left intercostal space, this suggests enlargement of the pulmonary artery. So if you have dullness to the right of at the level of the third and fourth interspace, above the area of the liver dullness, this may suggest enlargement of the right atrium. If you have an increase in dullness of the supracardiac area, this suggests aneurysmal dilatation of the aorta on the right side, and similarly on the left side at the level of the first interspace. So I guess that's my last slide. Thank you for listening. Because next meeting, we will be discussing on the murmurs already. So do you have a question? Wala